All right, chapter 34, shock and resuscitation. Perfusion means different things to different people, but to me, perfusion means that blood full of oxygen and nutrients go to an organ, through an organ, and exits oxygen depleted and full of cellular waste. Now, in order for perfusion to be adequate, there are three main things that we need. Some people will relate perfusion with blood pressure. If you have an adequate blood pressure, you're adequately perfusing your vital organs and your vital tissues. The three things we need for adequate perfusion are a functioning pump, a set of pipes that can constrict and dilate as necessary to keep the pressure up in the system, and an adequate volume to fill those pipes. Now there are some other things that we could throw in there as well, an adequate number of red blood cells, those sort of things. Shock, by definition, is inadequate tissue perfusion. So when somebody's in shock, they're not getting oxygen to their tissues. And that's an important concept. There's a wide variety of types of shock, causes of shock. We don't treat all shock the same way, as you'll see. But the whole concept of shock is that for whatever the reason or the cause, the patient isn't getting oxygen to their tissues. Now, one of the important aspects of perfusion is blood. And blood contains plasma. And plasma is your transport medium. Within the plasma lie the cellular nutrients, the electrolytes to include your potassium, sodium, calcium, magnesium, proteins, clotting factors, antibodies, and hormones. We often think of hormones as being estrogen and progesterone, testosterone, and certainly those are hormones, but epinephrine is a hormone. Acetylcholine is a hormone. So there are a variety of different hormones that we find in the blood as well. Also within blood are red blood cells, and they make up about 40 to 45% of your blood volume. And we know the important thing about red cells is that they contain hemoglobin. And hemoglobin binds with oxygen and then carries the oxygen to the tissues. Now, when you don't have enough red cells, that's known as anemia. So if you're anemic, you have a low hemoglobin or you have low red blood cell count. Now, there are different types of anemias. There's hemorrhagic anemia, and we often don't call it that, but that's certainly what it is. When you bleed and go into hemorrhagic shock, one of the reasons that you're in shock, lack of adequate tissue perfusion, not being able to get oxygen to your cells, is that you've lost the ability to carry oxygen by the loss of the red cells. Then there's also hemolytic anemia, and this is when the red blood cells die sooner than they can be produced. You know that red cells are produced in the bone marrow, and they last about 7 days, and then they have to be replaced. In hemolytic anemias, the red blood cells die sooner than they can be produced, and there's a variety of different causes of hemolytic anemia. White cells, we know, fight infection. They consume pathogens. White cells produce antibodies. And we know that platelets are responsible for clotting. They are also assisted by fibrinogen fibers. Rich red fibrinogen fibers weave their way through the platelets when they aggregate or stick together. Now, most cells are round. Platelets are not round. They have all these little projectiles or little fingers sticking out from them. And when they get together, when they aggregate, they have a tendency to clump up. And then in comes that rich red fibrin weaving through those platelets to help solidify and form a clot. Fibrinolytics lyse the fibrinogen, dissolve it so that the clot can dissolve. And you'll certainly learn about TNK, all the different TPAs that are used for both stroke and STEMI. Now, blood vessels, we'll talk first about the arteries. We know that the arteries are under a greater pressure than the veins. We know that they are conductance vessels. They carry blood from the heart to the arterioles, and as I had mentioned, under some pretty high pressures. Here's a, if you will, a schematic or a diagram of your systemic and pulmonary circulation, where veins, or the venules of each organ, and the veins from each organ dump their oxygen poor blood into the venous side, and through the superior inferior vena cava, they end up in that right atrium, in the right ventricle. The right ventricle then pumps that blood through the pulmonary arteries to the arterioles and capillaries that surround the alveoli, and then gas exchange takes place. The CO2 is eliminated, oxygen is added, and then the blood flows from venules to veins, the pulmonary veins, into the left atrium, the left ventricle, and then out the aorta to all parts of the body. And as you can see, this is a closed system. It's not full all the time, but it should be relatively full. And when you get a hole in this system, it will leak. There are some other things that will cause this system to fail as well, and we'll discuss that. Arterioles are the smallest branches of arteries, and they connect arteries to capillaries. Precapillary sphincters contract and relax to push blood through the capillary beds. Now, smooth muscle is found in the vessel walls, and it allows for the vessels to dilate and constrict. And this is known as either peripheral vascular resistance, the size of the vessels in the periphery, or systemic vascular resistance, the size of the vessels in the systemic circulation. When your vessels constrict, you increase peripheral vascular resistance or systemic vascular resistance. When your vessels dilate, the pressure drops in the system. So you decrease peripheral vascular resistance or you decrease systemic vascular resistance. I liken this to a garden hose. This is just a good analogy of how our body can regulate the flow of blood by constricting and dilating the blood vessels. If you look at a garden hose, water flows out of the end of that garden hose at a certain pressure. But if I take my thumb and I put it over the end of the garden hose, you can see that the pressure of the water increases. And that's exactly what your body does. When it needs to decrease peripheral vascular resistance, the vessels dilate. When it needs to increase the pressure in the system, the vessels constrict. Now, capillaries are the smallest blood vessels. They connect arterioles to venules. And these are exchange vessels. Capillaries are where cellular respiration and the exchange of gases and wastes take place. Venules are the smallest branches of veins, and they connect the capillaries and the veins. You have postcapillary sphincters that also control blood flow from the body to the tissues. Veins carry deoxygenated blood from the body to the right side of the heart, as we've already mentioned. And these are called capacitance vessels because about 70% of your blood is stored in your veins and only 30% in the other side of the system. Venous blood flow depends on skeletal muscle action, respiratory movements, and gravity. Venous vessels do not constrict and dilate. Valves in the larger veins of the extremities and the neck are arranged to allow blood to flow in only one direction, back towards the heart. And you may hit one of those valves if you haven't already in your clinicals when you're starting IVs and doing those things. They can be problematic. The heart consists of the vena cava, dump blood into the right atrium through the tricuspid valve to the right ventricle through the pulmonary valve, through the pulmonary arteries, to the arterioles, capillaries. Gas exchange takes place in the lungs, then the blood flows through the pulmonary veins to the left atrium, from the left atrium through the mitral valve to the left ventricle out the aorta, through the aortic valve into all parts of the body. We learn this in EMT class, how blood flows through the heart. And it's a common theme that we reiterate all the way through your training. There's something also about the heart. It's known as an atrial kick. And that's when the atrium contract. By the atrium contracting, they push blood into the ventricles, that last little bit of blood. When people are in a rhythm called atrial fibrillation, the atrium fibrillate. So they don't squeeze hard. They don't contract. They just quiver. People can live in atrial fibrillation if the rate is within normal limits. It's not too slow or too fast, because blood flows from the right and left atrium into the ventricles by nature of the pressure in the system. But the atrial kick, that when the atrium actually contract, helps squeeze that last little bit of blood into the ventricles. Now, preload is the amount of blood in the ventricles before contraction. Stroke volume is the amount of blood ejected with each contraction out the left ventricle. And cardiac output, which is a factor of blood pressure, is determined by heart rate times stroke volume. Afterload is the pressure in the aorta that the left ventricle must pump against in order to move blood. Now, when you look at a blood pressure, 120/80, that tells you that when the left ventricle contracts, the pressure in the system is 120. When the left ventricle relaxes and fills, the pressure in the system is 80. So the left ventricle has to exceed 80 millimeters of mercury in order to move blood through the body. The higher the blood pressure, you get up into the 160s over 96 or 160 over 110. When you get pressures that high, that left ventricle has to work really, really hard in order to move blood throughout the system. And the harder it has to work, the greater risk there is of failure and cardiac disease. So that's why maintaining a normal blood pressure, 120/80, is so vitally important. So here's just, again, a diagram that talks about what preload is and how blood flows through the heart and what afterload is. Now, we will give medications that will decrease preload. Whenever we cause the systemic and peripheral vessels to dilate, the blood's going to pool out in the periphery, and that means less blood coming back to the heart. So there will be less preload. If there's less preload, less blood coming into the heart, it just stands to reason that there's going to be less blood going out of the heart. So one of the consequences of decreasing preload is you're going to drop the blood pressure in the system. Nitroglycerin, of course, is known to decrease preload, as is morphine. So giving those medications increases our risk of dropping the blood pressure. So shock, as we had mentioned, is a state of inadequate tissue perfusion, and it can be the result of failure of the heart, so you don't have an adequate pump. It could be failure of the blood vessels, in other words, they fully dilate. It could be loss of blood volume, and it also could be related to the inability of red cells to deliver oxygen to the tissues, and that's called offloading. And offloading occurs at the capillary level, where the red cells are supposed to offload those oxygen and nutrients to the individual cells. That can be affected by temperature. That can be affected by acid-base balance. That can be affected by lack of red cells in somebody who's anemic. So all those things are going to lead to shock. And most of us have learned that shock is divided into 3 stages. Early or compensated shock, the body compensates. The autonomic nervous system is stimulated by the result of a decrease in PaO2 and an increase in carbon dioxide. So since shock is a state of inadequate tissue perfusion, if I'm not perfusing, I'm not getting oxygen to the cells. So my oxygen concentration is going to drop. In addition to that, if I'm not circulating blood to the tissues as I should, I'm not eliminating CO2 either. So subsequently in shock, you not only get a drop in oxygen saturation, but you get an increase in CO2. Those 2 things trigger the release of epinephrine and norepinephrine. Epinephrine, as we'll see, is both alpha and beta properties. Norepinephrine has some alpha properties. It also activates the renin-angiotensin-aldosterone mechanism, which in the end leads to potent vasoconstriction, as we'll see. Also, your own endogenous vasopressin is released. Vasopressin is an antidiuretic hormone. It tells your kidneys not to diurese, to hold that water back, because you're going to need that to keep the volume expanded. Intracellular fluids also shift into the bloodstream. So volume that is in the cells shift into the bloodstream in order to maintain adequate perfusion. And this all occurs during the compensated stages of shock. And as these individual things occur, we can pick up or see signs and symptoms. So here is just, again, the picture of the adrenal medulla, the inside of the adrenal gland that sits on top of the kidneys. And little history lesson here. Epinephrine is a Greek word. Epi, if you look at your medical terminology, epi means on top of. Nepher refers to the kidney. So epinephrine is a hormone that is secreted on top of the kidney. And that's where the adrenal gland is. Some call it adrenaline, and the Greeks called it epinephrine. With the renin-angiotensin-aldosterone mechanism, the liver releases, and the kidney and the liver release angiotensin and renin. The combination of angiotensin and renin make a substance known as angiotensin 1. Within the capillary walls, an angiotensin converting enzyme, or ACE, is released and combines with angiotensin 1 to form angiotensin 2. Angiotensin 2 stimulates the adrenal cortex to release adrenaline and also release aldosterone. Aldosterone will send a signal to the kidney and tell the kidneys to hold sodium. Don't get rid of sodium. You probably learned at some point water follows sodium. So if the body is retaining sodium, it will also retain water. And by doing so, it will keep the volume expanded. On physical exam, one of the first things you're going to see in early compensated shock is an increase in respiratory rate. Remember that shock, by definition, is lack of adequate tissue perfusion. In other words, we're not getting enough oxygen to the tissues. And that drop in your oxygen saturation causes you to take in deeper breaths at a faster rate. It's called quiet tachypnea. If you're looking at a sick patient and the respiratory rate is increased, labored, but their sats are 98% and their lungs are clear and they're not short of breath, you got to wonder why they're breathing so fast. And that could be a very early sign of shock. Next, the heart rate will go up with the release of epinephrine and norepinephrine. Initially, your pulses are going to be bounding with the release of epinephrine. You're going to easily palpate them. But as shock continues, the peripheral pulses decrease in strength, become weak, thready, and fast. And at some point, if the pressure gets low enough in the system, you'll lose those peripheral pulses. We're often taught that if you cannot palpate a radial pulse, then the blood pressure is less than 90. You also want to assess the adequacy of end organ perfusion, and that's not something we would do in the field other than perhaps looking at skin color, temperature, and moisture. The skin, being your largest organ, is going to show lack of adequate perfusion because it becomes pale, cool, and it becomes clammy because sweat glands are under the control of adrenaline as well. So the more adrenaline that's dumped into your system to help you compensate, the sweatier you're going to get. Now, compensated shock is reversible if we can identify the cause and fix it. If we can't identify the cause and fix it, it will progress to decompensated shock. Now, in decompensated shock, epinephrine and norepinephrine are still being cranked out, but in larger amounts. All the compensatory mechanisms fail. The liver and the spleen start releasing red cells and plasma in an attempt to improve oxygenation. The precapillary sphincters, which were constricted, dilate, and blood rushes into the capillary beds with this new addition of red cells, hopefully to perfuse your vital organs. But when the precapillary sphincters dilate, the postcapillary sphincters constrict. So the blood rushes into the capillaries but has nowhere to go. So it becomes stagnant and just builds up with cellular waste, and anaerobic metabolism occurs. Anaerobic metabolism is an means without. Aerobic has to do with air, or oxygen. So this would be metabolism without oxygen. And whenever we metabolize without oxygen, the end product is lactic acid. So the longer we allow anaerobic metabolism to occur, the more acidosis we get. When you metabolize with oxygen, 1 molecule of oxygen creates about 22 molecules of energy, adenosine triphosphate. When you metabolize without oxygen, you still produce energy, but you only produce 1 or 2 molecules of adenosine triphosphate. So it's not a very effective system. It will provide a small amount of energy that may keep you alive during the compensatory phase. But in this phase, too much acid has dumped into the system, causing your acid-base balance to get out of whack. More lactic acids get into your blood. Acids liberate hydrogen ions. The increase in hydrogen ions is going to drive your pH lower and make your blood acidic. Now, you couple acidity, that's one of the things that has to be relatively in that 735 to 745 range in order for oxygens to offload. So when you become acidic, any oxygen you may get into the system may have trouble offloading. So here's a very complicated flow diagram that just describes most everything that we've talked about. Keep in mind that along with not getting oxygen to tissue during shock, you also don't get any cellular nutrients. So making energy and feeding the cells, is severely limited when you're in shock. And acidic blood has a negative inotropic and chronotropic effect on the heart. If you remember from your pharmacology, inotropes affect the strength of contraction, and chronotrope affects the rate of contraction. So if a person is acidic, their heart's not going to beat as strong or as fast. And that's going to decrease cardiac output, and that's going to drop your blood pressure. Now, irreversible shock is when the hypoperfusion causes anaerobic metabolism. You get all this acid in the system. Cardiac dysrhythmias lead to decreased cardiac output. Exotoxins are released. They enter the blood. They spread throughout the body. These exotoxins damage cells. Cells, when they are together, form tissue. Tissue is specialized, so a collection of liver cells would be liver tissue. A collection of liver tissue makes up the liver, which is the organ, and a collection of organs make up the organism, which is us. So we have vital organs, and during irreversible shock, the damage from anaerobic metabolism can be serious enough that if enough cells die, the tissues die. And if the tissues die, the organ dies. And if the organs die, the organism dies. And it doesn't happen immediately. Oftentimes, a week or two after we successfully resuscitate somebody from this stage of shock, they go into multiple organ dysfunction syndrome, or MODS. They also can damage the lungs to the point where they develop adult respiratory distress syndrome, and that term has been changed. It's now called acute respiratory distress syndrome, or ARDS. And you can also develop renal failure, so it could be a acute kidney injury from this acidosis, or acute renal failure, which is ARF, acute renal failure. Now, shock is categorized by the mechanism, and we're going to look first at hypovolemic shock because that is how we learned what shock looked like. When we were first taught what shock was, it was all based off loss of volume. So hypovolemic shock is inadequate tissue perfusion caused by not having enough blood in the system. It can be caused by hemorrhage, which could be internal or external, but it's got to be major blood loss, at least 25 to 30% of your blood volume. It can also be related to plasma losses, or third spacing, which is interstitial fluid volume in your blood vessels leaking into the interstitial space. Burns will cause hypovolemic shock just from plasma loss. Diabetes insipidus, or diabetes, certainly will cause a mild form of hypovolemic shock because of the osmotic diuresis as you attempt to pee out all that sugar. And then vomiting and diarrhea certainly are a form of volume loss as well. Now, blood loss of less than 15% is generally well tolerated, but remember with kids, they have a lot less volume than we do, so they can't afford to lose 15% of their blood volume. One of the formulas for determining blood volume is to take 8 plus 2 times their age in years, which will equal in this case, 2 kilograms in this 2-year-old. Excuse me, 12 kilograms in this 2-year-old. You take that times 70 mils per kilo, so you end up with 840 mils. That's the amount of blood a pediatric patient, this 2-year-old pediatric patient would have. And as you get older, the volume does certainly increase. When blood volume is decreased, venous return is decreased. So when preload is decreased, cardiac output is decreased, blood pressure drops, and blood flow to the vital organs is decreased. Some signs and symptoms of hypovolemic shock include thirst, weakness, normal to minimally impaired loss of consciousness in the early stages of compensated hypovolemic shock. You're going to get pale, cool, clammy skin, maybe even some mottling, mild tachycardia in the low hundreds, but the blood pressure is relatively normal, and pulse pressures are relatively normal as well. During decompensated shock, hypovolemic shock, the compensatory mechanisms fail. And when the compensatory mechanisms fail, you no longer can adequately perfuse your vital organs. And the first organ to show dysfunction is the brain. So you're going to end up with altered level consciousness and decrease in pain responses. If the hypovolemia has occurred over a longer period of time, the mucous membranes may be dried and furrowed, as in the case of vomiting and diarrhea, or diabetic ketoacidosis, those sort of things. Skin is pale, mottled, cyanotic. Heart rates are in the 130s, 140s, 150s. Pulses are weak, if palpable at all. Blood pressure starts to drop, as do the pulse pressures. Now, pulse pressure is just the difference between the systolic and the diastolic blood pressure. Irreversible shock. Remember, this is a shift in metabolic, with significant metabolic acidosis. The brain does not function when it's dry and being bathed in acid, so you become extremely lethargic to unresponsive. You become limp. You're up there with respiratory rates in the 30s, high 30s, to no breathing at all, or very sporadic breathing. Skin is mottled, your trunk is blue, your heart rate's in the 140s, 150s, and now begins to deteriorate to bradycardia, and blood pressure may be unobtainable by a stethoscope and a blood pressure cuff. Now, therapeutic interventions for hypovolemic shock are really to replace the volume with something that carries oxygen, and that's not anything that we can do. What we can do is that we can maintain the ABCs, make sure that their airway is open and patent, suction if necessary, position is needed, make sure that they're breathing at an adequate rate and depth, supplement that with oxygen. If they are bleeding, control hemorrhage externally with direct fingertip pressure, packing the wound, or a tourniquet. And then high concentrations of oxygen, if necessary. In other words, their Glasgow Coma Scale is less than 8. We may need to protect their airway with a King or an endotracheal tube. Keep them flat, keep them warm. I can't stress enough the importance of keeping a shock patient warm. Lack of adequate tissue perfusion means we're not getting oxygen to the cells. Not getting oxygen to the cells means we're not producing energy. One of the things that occurs when we produce energy is we generate heat, and heat keeps our temperature up. When a person is in shock, they're not generating heat. Their body temperature drops. They become hypothermic. They begin to shiver. They burn up energy they don't have to waste. So keeping them warm is vitally important. Monitor their heart rate. Pulse oximetry may or may not be reliable. If there's no good pulsatile flow to the digit or the earlobe, you're not going to get an accurate reading. Capnography, watch for that CO2 to go up as shock worsens. Now, we're going to replace volume, and ideally we should replace it with packed red cells, fresh frozen plasma, and platelets. However, none of those things are routinely being carried in EMS. There is some research being done in Denver with fresh frozen plasma and administering that to patients, thawing it out and administering it to patients who have hypovolemic shock with really, really good results. They've been doing this study for about 3 years, and they hope to publish soon. I think maybe what they're waiting for is in Europe, they're using freeze-dried fresh plasma, and they reconstitute it and then administer it, and they're seeing similar results. So ideally, that's what we should do, but we don't have those things. At least most of us don't. So we rely on a isotonic solution like normal saline. The issue here is that with just the administration of 750 milliliters of normal saline, we can cause DIC, disseminating intravascular coagulation. And we do that by increasing the pressure in the system to the point where any clots that had formed pop, and bleeding, internal bleeding, may continue, and they may lose more platelets. And by loss of platelets, if they lose enough of those, they're not able to clot at all. So we can precipitate that by 2 large bore IVs wide open, and that's just not something we should do. In fact, the recommendation is if their pressure is above 90, or better yet, if you're monitoring the mean arterial pressure or the MAP on your monitor, if their MAP is above 65, they don't need any IV fluids. It's okay to start one so that you have it there in the event that you need it, but we're going to practice what's called permissive hypotension. We're going to keep their pressure around the 90 mark. If it's greater than that, great. We don't have to worry about anything. They don't need any volume. But if it's less than 90, we're going to give them small infusions, 250 mils at a pop, and reassess their pressure to make sure that we keep it around that 90 or the mean arterial pressure around 65. Whether or not you use pressors is debatable. It just depends on each individual situation. In other words, starting a dopamine drip or starting norepinephrine, which will vasoconstrict, make the heart work harder as a pump, and all those other things, but can raise the pressure to the point where you pop all those clots, and now we got problems. And that's only referring to internal hemorrhage. External hemorrhage is a different animal. Check lung sounds before giving fluid boluses, because certainly if the cause of this shock is not hypovolemia, but something like cardiogenic, then they may have wet lungs, and giving them fluid just may make that worse. You may need to repeat your bolus in order to maintain that systolic pressure around 90 and recheck the patient response as you can. So here is normal circulation on the left, and then with hypovolemic shock, in order to maintain adequate tissue perfusion, you have vasoconstriction. And that occurs from the release of things like norepinephrine. Epinephrine is going to increase the heart rate and strength of contraction in order to maintain pressure in the system. Now, cardiogenic shock, cardio refers to the heart, genic is genesis. So the genesis of this shock is the heart. It's impaired pump function. When the pump does not work properly, you're going to have a decrease in cardiac output and a drop in blood pressure. And cardiogenic shock is determined by looking for things in the cardiovascular system, or I said things, but you're essentially looking for differentials as to why this person is in shock. Things like an acute myocardial infarction, if they're having a STEMI, then certainly that can lead to cardiogenic shock, particularly if we're looking at a LAD, if we're looking at something obstructing the left coronary artery. A congestive heart failure, which occurs over a period of time. CPR, certainly a person is in cardiogenic shock if we're having to do closed chest compressions. An aneurysm is sort of a combination between hypovolemia and recommend cardiogenic shock, particularly if the aneurysm is the thoracic aorta and it dissects back against the heart itself. It can almost lead to a very similar presentation as STEMI when that occurs. And then certainly a rupture of the heart itself, from trauma to the chest, that sort of thing. So some possible causes of cardiogenic shock include a myocardial infarction, prolonged cardiac surgery, ventricular aneurysm, ventricular wall rupture, cardiac dysrhythmias, rupture of the ventricular septum, myocarditis, which is an inflammation of the muscle tissue of the heart, cardiomyopathies, myocardial trauma, heart failure, hypothermia, severe electrolyte and acid-base imbalance. Remember those, if you're very acidic, your organs don't like to function at all. And then severe cardiac heart disease. And again, here they're showing a normal circulation on the left, and on the right we have damage to the pump, pointing there to the left ventricle, which I'm assuming they're trying to illustrate as STEMI, ST segment elevated myocardial infarction, so heart attack, which would decrease the heart's pumping ability because dead tissue, that purple patch there would represent dead tissue. Dead tissue does not contract, nor does it conduct electricity. And that's going to decrease circulation to all parts of the body. The other thing to keep in mind about cardiogenic shock is the left side of the heart receives its blood supply from the lungs. So when we have pump failure, blood is going to back up into the lungs and back up into all parts of the body. When the right side of the heart fails, we see things like jugular vein distension, pedal edema, sacral edema, those sort of things. But when the left side of the heart fails, blood backs up into the lungs and we see acute pulmonary edema. So with cardiogenic shock, we're going to see a decrease in level of consciousness from a low blood pressure. We're going to hear crackles in the lungs from blood backing up into the lungs. Blood pressure is going to drop, jugular vein distension. You could have weak, rapid peripheral pulses with narrowed pulse pressures. Systolic and diastolic are pretty close together, particularly in the case of like a cardiac tamponade. Skin becomes cool, pale, mottled to cyanotic, and muffled heart tones, which when they're referencing Beck's triad here, it's a triad of three things that we would see in somebody with severe heart failure. Now, most often than not, when we're talking about Beck's triad, they're referencing a pericardial tamponade, which is heart failure, but from a different mechanism. The muscle itself is fine. The heart is obstructed from fluid accumulating in the pericardial sac. So some would put Beck's triad, muffled heart tones, narrowing pulse pressures, jugular vein distension, all in obstructive shock and not cardiogenic. So some differential diagnoses or things that cause cardiogenic shock include an acute coronary syndrome, whether that be angina, unstable angina, NSTEMI or STEMI, aortic dissection, myocardial rupture, myocarditis. There could be some respiratory causes for cardiogenic shock, pulmonary emboli. Again, when you're talking about respiratory and pulmonary embolism, you can pull those into obstructive shock because they're referring to tension pneumothorax or PE, which would obstruct the flow of blood through the capillaries, which would decrease your ability to get oxygen to your tissue, which would lead to shock, but it really doesn't have anything to do with the pump as much as an obstruction of blood flow from a clot. Hypovolemia and sepsis can cause cardiogenic shock as well. Treatment for that, they've not lost volume, so there isn't a big issue to give volume. Maintain their ABCs, high concentrations of oxygen, IV monitor, pulse oximeter and capnography. Remember, pulse ox may not be reliable if the pressure's low and they're cold. Treat your dysrhythmias, as you'll learn in ACLS, particularly bradycardias. Have to be really careful, and we'll talk about that in great detail in ACLS. And then, CPAP for congestive heart failure is an amazing tool, but remember, CPAP lowers your blood pressure by increasing intrathoracic pressure. So giving CPAP in somebody who's already has a low blood pressure is contraindicated. Check responses and vitals to your treatment. Make sure that you have an IV in the event that they arrest. Distributive shock. They have all the volume, it's just being distributed somewhere else. It's usually the result of vasodilation. The vessels fully dilate, the pressure in the system drops. So I liken it to your container is now twice as big, so it's half as full. And in order to maintain adequate blood pressure in that system, the heart's going to have to work much harder as a pump in order to keep the pressure up in that system until those vessels can become constricted. Now, one of the major causes of distributive shock is sepsis. Sepsis, which is an infection, a blood infection, a systemic blood infection, the toxins associated with sepsis cause the vessels to fully dilate. When the vessels fully dilate, blood pools out into the periphery and causes a drop in blood pressure. Sepsis may be caused from lactic acidosis. You may see decreased urine output with sepsis, sudden change in mental status with sepsis. Most people are relying on the new criteria for sepsis, where they talk about a condition known as SIRS, Systemic Inflammatory Response Syndrome. And to have SIRS, you need one of these two things. You need tachypnea, really fast really fast respiratory rate. You need tachycardia, really fast heart rate, temperature, you need a temperature above 1014, and then an elevated white count above 12,000. So if you've got two of one of these things and you have a source of infection, then you're preseptic. And it's very important in that situation that we lower fever, we administer lots and lots of fluid, and we get an antibiotic started right away. Sepsis certainly affect the very young and the very old harder than the rest of us. Those with comprised immune systems can become septic. Those who are malnourished can become septic. Those who use long-term antibiotic and steroid use may not have the ability to fight off certain antigens as they begin to change as they evolve and become resistant to some of the common antibiotics. 20 to 35% with severe sepsis is the mortality rate. 40 to 60% who develop shock with sepsis will die within 30 days from, again, the organ failure. Now here again, the normal perfusion on the left, and with sepsis you have a general vasodilation of the arteries. Blood pools out in the periphery, and that drops the blood pressure. Now, the unique thing about sepsis is because these vessels dilate, is blood initially pools out here in the periphery, so this one will fool you. Your patient's going to be pink, warm, and moist. They're going to have bounding radial pulses, but you got to put in there the tachypnea, the tachycardia, the temperature, and a source of infection to be really highly suspicious of sepsis. Sepsis can be caused by heart problems, can be caused by shock, other shocks, acute MI, myocardial rupture, certainly things like pneumonia, pulmonary embolus, endocrine issues, diabetic ketoacidosis, hyperthyroidism, renal failure, adrenal crisis, anaphylaxis, aspirin toxicity, disseminating intravascular coagulation, and heat stroke. Certainly if those are within the history of this patient's presentation, it could be a septic issue. In the hyperdynamic state of sepsis, the early state of sepsis, Some of the things you'll see are warm skin, it's dry, it's flushed. They're going to be tachycardic and tachypnea. They're going to have a normal blood pressure. The peripheral pulses will be bounding. So that'll kind of fool you because it doesn't look like all the other shocks. But later in sepsis, during the hypodynamic state of sepsis, their skin becomes mottled and cold. You're not able to palpate peripheral pulses. Their mental status is altered. They remain tachycardic, they remain tachypnic, but also they develop a rash. It's called purpura. And purpura is a non-blanching purple raised rash that kind of looks like the hives. But hives are red, not purple, and hives blanch when you touch them, and purpura does not. You want to make sure that when you're thinking about sepsis, where the site is for the diagnosis. Where is the site of infection? Is it in the cardiovascular system? Is it in the respiratory system? Is it a cause of the endocrine system, or is it some other cause? Treatment for sepsis: ABCs, oxygen, IV, monitor the heart rate, vital signs frequently, pulse oximetry, capnography, position of comfort. For some in septic shock, they may need to lie flat. Others may need to sit up in order to breathe. You certainly can give them a fluid bolus, 20 mils per kilo, checking for lung sounds each time you do that. And then check the response to that fluid bolus. Again, checking for lung sounds before you give them another fluid challenge. In smaller children, and certainly smaller adults, a 20 mil per kilo bolus is about 25% of their total volume. So by giving a 20 mil per kilo bolus in any patient, you've replaced 25% of their volume, and you should see a significant improvement in vital signs. If you don't, they are really, really dry. The other thing that occurs in sepsis that we don't has not been mentioned here is an increase in capillary permeability. When blood pools out here in the periphery, when blood floods those capillaries, the pressure inside the capillaries becomes so great that blood starts to weep out of the capillaries into the interstitial space. It's called third spacing. So now your bucket that is twice as big and is half as full is now full of holes. And we see that in the late stages of sepsis, and we also see it as evident by rashes like petechiae and purpura. Anaphylactic shock or anaphylaxis is another form of distributive shock. When a body is exposed to a allergen, if it responds with a severe allergic reaction, one of the consequences of the release of histamine, one of the consequences of the release of bradykinin and all the other chemicals that are released during an allergic reaction, cause the vessels to fully dilate, and in later stages also cause the rashes. Shock or anaphylaxis can be caused by allergies to dust, pollens, molds, animal danders, milk, eggs, peanuts, shellfish, and beans. Latex and rubber products, although we don't see much of that anymore because most of the latex has been eliminated. If you give a blood transfusion, maybe parts in the blood, the RH factor, the ABO system, if they're not matched and typed correctly, there can be a blood transfusion reaction which could lead to anaphylaxis. Antibiotics, particularly penicillin, Hymenoptera envenenations, in other words, being stung by a bee. Local anesthetics, they can be allergic to. Vitamins, NSAIDs like aspirin, ibuprofen, IV contrast dyes, radio contrast media, and again aspirin by itself. Here is just all the things that occur when you have your first exposure to an allergen. Your immune system kicks in immune globulin E, mast cells and basophils combine with the immune globulin E to form or help you create an antibody. When you're exposed to it again, that's where these mast cells, in a response to exposure to the allergen, release large amounts of histamine, bradykinin, and there's 4 other chemicals that are released. And these cause inflammation, dilation of the vessels, which leads to the edema, the redness. The pruritus refers to the rash and itching that you may get with a simple allergic reaction. Now, anaphylaxis and allergic reaction are 2 entirely different things from the standpoint that an allergic reaction is hay fever. Maybe miserable, but it's not life-threatening. However, anaphylaxis is truly a life-threatening condition where you get exposed to an allergen, and then antigens in the body attach to the immune globulin E antibodies on the mast cell, causing a huge release of histamine and bradykinin, which dilate the blood vessels, which constrict bronchioles, and those sort of things. And that's why we give epinephrine initially, not to stop the allergic reaction, because all the epinephrine's going to do is open up the bronchioles so that you can breathe and perhaps constrict those vessels so that the pressure is maintained in the system. But then we need to come along with a antihistamine to stop the production of histamine. Your first exposure in anaphylactic shock or anaphylaxis, you have a sensitization caused by the antigen-allergen reaction. The immune system responds by forming immune globulin E antibodies, and the antibodies attach to the mast cells, creating sensitized mast cells. And then when they're exposed again, those mast cells release histamine, which cause vasodilation, increase capillary permeability, so you get a lot of third spacing with that as well. You get redness, you get itching, and as the histamine continues to be released by the mast cells, they irritate nerve endings, they cause constriction of the larynx and bronchioles, can cause angioedema, tachypnea, tightness in the throat or chest, stridor, difficulty in breathing, wheezing, hoarseness, cough. You can get accessory muscle use from having to work so hard to breathe, tachycardia, drop in blood pressure when the vessels fully dilate. You get the urticaria or the hives, the itching, pale, nausea, vomiting, and diarrhea because you get a lot of abdominal cramps and can have incontinence of stool because of all those abdominal cramping from the release of the inflammatory chemicals in the body. And of course, anxiety would be an early sign in somebody who's in shock. Some cardiovascular findings associated with anaphylaxis may include an acute coronary syndrome, perhaps initially an aortic dissection, cardiogenic shock, dysrhythmias, and hemorrhagic shock occurs on the back end with an increase in capillary permeability, and so now these vessels that are dilated from the release of chemicals during the allergic reaction have dropped the pressure in the system, but all this blood pooling out in the periphery increases the pressure inside the capillaries, causing them to weep or leak or hemorrhage into the tissue. Some other things you may rule out with anaphylaxis is because they may have some upper airway swelling. You might think, oh, well, it's anaphylaxis. You need to make sure they don't have a foreign body airway obstruction. Pulmonary embolism can also cause shortness of breath. Reactive airway disease is a mild form of asthma, but severe cases of reactive airway disease certainly can lead or look like anaphylaxis. Tension pneumothorax will cause shortness of breath. As far as the endocrine system goes, hyperthyroidism may mimic that. Insulin reaction, panic attack, vasovagal syncope. If I'm having trouble breathing and I'm really stressed out, one of the other hormones that I'm going to dump into the system, especially if I'm working hard to breathe and grunting and doing all that sort of stuff, is acetylcholine. And acetylcholine causes the heart rate to slow down. So if I dilate my vessels and my heart rate slows down during this anaphylactic reaction, my blood pressure is going to drop significantly and I may pass out. So with anaphylaxis, the one thing that probably separates it from other shocks is this development of the hives or urticaria. Top right-hand picture, you can see those hives, raised red rash bumps all over the body that you can press and they will blanch, and that's all in relationship to the histamine release. And then you look at a picture here of this woman in 4 different phases as she develops angioedema. So this is angioedema, and angioedema can become so severe that obviously she can't open her eyes. She would have difficulty breathing, in addition to her cheeks and face and lips swelling huge. Her tongue may also swell, causing airway obstruction. So angioedema can be serious if it certainly reaches the stages as it does in picture D here. Oftentimes you'll see this in women who have just been started on an ACE inhibitor. Gastrointestinal and genitourinary findings that we can see with anaphylaxis that we often overlook and forget: nausea, vomiting, and diarrhea, abdominal cramping, incontinence may also go along with anaphylaxis. Again, we're going to assess all the systems to make sure that there isn't a cardiovascular problem causing this, a respiratory problem causing this shortness of breath, an endocrine problem causing what it is that we're seeing. But anaphylactic shock, has that classic presentation with perhaps angioedema, definitely urticaria, increased work of breathing, wheezing, stridor, all those sort of things. Treatment for anaphylactic shock includes ABCs, high flow oxygen. Certainly if they're shutting down, as evident with stridor, low sats, high end tidal CO2s, we need to consider taking care of their airway before they completely shut. IVs and heart monitors, vital signs, pulse oximetry and capnography should be monitored as well. On a capnograph, you may see some shark fin waveforms, which would indicate bronchospasm. IV access. Now remember, in anaphylaxis, their vessels are fully dilated, so their container's half as full. So it is appropriate to give them, large fluid challenges in anaphylaxis. They need some epinephrine IM or IV. The epinephrine IM is 1 to 1,000 epinephrine, and it's 0.3 to 0.5 milligrams given IM. Or if you're going to give the IV epinephrine, it's based on body weight, usually not to exceed 0.5 milligrams of a 1 to 10,000. But if you're given an IV, remember to give it very slowly over a period of about 3 to 5 minutes. They also need a histamine, an antihistamine. So Benadryl, which is something that we all carry, and we should administer either IV. It can be administered IM, but it's just going to take a lot longer to work that way. Steroids, they take hours to work, so the sooner we can get those started, the better. We may have to give them pressors like norepinephrine or dopamine in order to get their pressure up, and don't forget an H2 blocker like Tagamet for the abdominal cramping and that sort of stuff. Check their vitals frequently to see how they respond to your treatment, and this would be one that you'd reassess every 5 minutes. Now, neurogenic shock is disruption of the autonomic nervous system or the sympathetic nervous system, and it results in massive vasodilation. So neurogenic shock is caused when the vessels fully dilate, your container becomes twice as big, and the issue isn't the vessels dilating from a toxin or the vessels dilating from histamine, as is the case for anaphylaxis and septic. Some people will put neurogenic shock in the category of distributive shock. General anesthesia may cause neurogenic shock. Spinal anesthesia may cause neurogenic shock. Ingestions of barbiturates and phenothiazines. Injury to the head or spinal cord above T6. Now, when you have a high spinal cord injury, like above T6, that's going to cause the vessels to fully dilate below the injury. But in addition to dilating the vessels, that's the loss of the sympathetic tone, you also lose the ability to increase your heart rate normally through your normal mechanisms. Because remember, it's the sympathetic nervous system, the release of adrenaline or epinephrine, that increases your heart rate. So the loss of sympathetic tone, these people will, in addition to from the injury down, be pink, warm, and moist because the vessels are fully dilated. Their pressure is going to be low, and their heart rate's going to be low. They may even be bradycardic. Spinal cord injury is the most common cause of neurogenic shock. Certainly tumors of the spinal cord can cause it as well. You want to assess for pain, paresthesia, loss of level of consciousness. Remember that vasodilation occurs below the injury, so below the injury is fully dilated, pink, warm, moist. Above the injuries, the vessels still constrict, so though above the injury, you'll see pale, cool, clammy skin. So you just see this clear line of demarcation in these patients that have neurogenic shock from spinal cord injury. You have a widening pulse pressure with an eventual decrease in blood pressure. That slow bradycardia as a result of unopposed parasympathetic stimulation, and then an increase in respiratory rate. Skin will be pale, mottled, and cyanotic above the injury, pink, warm, and moist below. Manual C-spine if it's caused by spinal cord trauma. Open the airway with a jaw thrust if they're unconscious. High concentrations of oxygen. Monitor their pulse oximetry and capnography to maintain SATs at 95%. Keep their end-tidal CO2 within normal limits as well, 35 to 45. Heart monitor, IV fluids. Again, you may have to give them quite a bit of fluids because their vessel's fully dilated in order to bring the pressure up in the system. You certainly can try a pressor. As far as medications go, Levophed, norepinephrine, which is norepinephrine, or dopamine, but they're not likely going to make those vessel constricts if that tone has been lost. IV O2 monitor, check their blood glucose level because they may have an altered mental status, and we should check the BGL in all patients with altered mental status. Reassess them frequently, and as with all shock, maintain body temperature. Obstructive shock is something is obstructing the flow of blood. That could be a tamponade, a tension pneumothorax, a massive pulmonary embolus. Something is just obstructing the flow. Cardiac tamponade results from fluid in the pericardial sac. Fluid is non-compressible. Hydraulics teaches us that if we take fluid and we put it under pressure, we can move buildings. It takes 300,000 pounds per square inch to compress liquid 1%. So we cannot compress a liquid. When liquid builds up in the pericardial sac, the heart's ability to relax and fill is impaired. And this impaired filling reduces cardiac output and preload. Reduction in preload reduces cardiac output. Reduction in cardiac output drops blood pressure. Eventually, the pressure in the pericardium becomes severe enough that the superior and inferior vena cava collapse, and then we have no blood flow and we end up in cardiac arrest. Now, tension pneumothorax is caused by air in the pleural space between the lung and the wall of the chest. That could be caused by a rib fracture. That could be caused by a bleb in the lung that ruptures. That could be caused by overzealous tidal volumes on a ventilator or when squeezing the bag mask. Pulmonary emboli results in a ventilation perfusion mismatch, and one way to know that you're dealing with PE as a cause of your obstructive shock is your SATs are going to be low, lungs are going to be clear, you give them 100% oxygen, and their SATs don't raise much at all. Do keep in mind that 1/3 of all pulmonary emboli have normal pulse oximetries and nice clear lungs. Left ventricular rupture due to an acute myocardial infarction or a cardiac tamponade can occur as well, leading to obstructive shock. So here's an example certainly of a tension pneumothorax. Air enters the pleural cavity between the lung and the chest wall. As air accumulates in that side of the chest, it collapses the lung and it pushes everything in the mediastinal cavity away from the side of the tension, which could put some pressure on the superior inferior vena cava and decrease blood supply that way. Look for a history of shortness of breath, sudden onset of chest pain. The patient, like all shock patients, may be anxious, have a feeling of impending doom, be restless, may have some chest tightness. If it's a pneumothorax, dizziness, pericarditis may be a diagnosis. Pericarditis, if left untreated, could lead to a pericardial effusion. The effusion could lead to pericardial tamponade, an end-stage renal disease. They're going to be short of breath, anxious, tachycardic, tachypneic. With a tension pneumothorax, they're going to have diminished or absent breath sounds on the side of the tension. With a cardiac tamponade, they're going to have muffled heart tones. If they're not oxygenating well, they're going to have an altered mental status. Like with all shocks, they're going to be pale, cool, and sweaty. You look at Beck's triad: jugular vein distension, muffled heart tones, narrowing pulse pressures. That'll clue you into a potential pericardial tamponade. Look for other cardiovascular and respiratory causes of the shock. With a tamponade, you need to do a pericardial centesis. That's not something we can do. About the only thing we can do for a tamponade is to give them a fluid bolus. By increasing preload, we may stretch the myocardium a bit, and it will respond with a much stronger contraction, maybe enough to move a little bit of blood. Tension pneumothorax, we need to put a hole in their chest. Big 3-inch needle, second or third intercostal space, mid-clavicular line, bury the needle, pull it out, leave the Jelco in place. If you want to seal it with an occlusive dressing, you certainly can. If you seal 3 sides, the belief is you have a one-way valve, so air can escape. If you seal 4 sides, the lung will re-expand, or you may develop another tension, in which case you can just burp the dressing by removing a couple of the sides. Keep in mind that, because you cover a wound, even with a flutter valve, that wound can seal itself back up. This is more common with an open pneumothorax, where you seal it with an occlusive dressing, and then the wound itself will seal, and then it progresses to a tension pneumothorax, and removing the occlusive dressing, because the wound has sealed, isn't going to release the pressure. You may have to needle a chest that you sealed an open chest wound with in order to get the pressure out. Dissociative shock, the heart volume and container are intact, but dissociative shock is caused by the inability of oxygen to reach the cells, and you can see this with CO2 retention. You can see this also with CO, inhalation of carbon monoxide, or cyanide poisoning. Some special considerations: remember that dehydrated patients have decreased fluid reserve, so we certainly need to hydrate them, and we can look for signs of dehydration. In the history, there would be certainly a history of nausea, of vomiting and diarrhea, decreased fluid intake. Their skin may be dried, their tongue and mucous membranes dried, tongue furrowed. no moisture in their eyes, poor skin turgor, all those sort of things we can look for. Pediatric patients don't have as much blood volume, so it doesn't take as much for them to go into shock. The kicker there is that they do have healthy hearts. So their compensatory mechanisms, the vasoconstriction and the increase in rate and strength of contraction, is often much better than in an adult. So they'll compensate for much longer periods of time before they collapse. Geriatric patients have decreased fluid reserves. They often have decreased functional residual capacity in their lungs. They also have certainly a decreased ejection fraction, and they just don't tolerate volume loss as well. Certain drugs that are given for hypertension may also affect the compensatory mechanisms, and they include things like beta blockers. We increase heart rate strength of contraction by releasing adrenaline from our adrenal glands, and the beta 1 effects of adrenaline cause our heart rate to go up. Now, if we're on a beta blocker, then the beta effects of adrenaline are shunted. Calcium channel blockers decrease heart rate and may not allow it to pick up by blocking the flow of calcium through the calcium channels. And then ACE inhibitors, they inhibit that angiotensin converting enzyme. And by inhibiting that angiotensin converting enzyme, angiotensin 1 is not converted to angiotensin 2, which is a potent vasoconstrictor. So vessels aren't allowed to constrict if you're on an ACE inhibitor, or it's limited as to what they can do. And then ARBs is the next generation better than an ACE inhibitor. They're angiotensin renin blockers, and angiotensin renin blockers do the same thing that an ACE inhibitor does, but further down the chain instead of in the lungs. All right, so we went through that pretty quick. If you have any questions, you know how to get a hold of me, and I'll talk to you soon.